Today I will be demonstrating the insertion, feeding, and removal of nasogastric tube. A nasogastric tube placed into the stomach allows the access to the inside of the stomach. Sometimes the tube is passed into the small intestine to allow entering feeding. Indications for nasogastric tube insertion: to decompress the stomach and gastrointestinal tract. This is to relieve the detention due to obstruction, ileus, and atony. To empty the stomach, for example, in patients who are intubated to prevent aspiration, or in patients with GI bleeding to remove the blood and plaques. To obtain a sample of gastric contents to assess bleeding, volume, or acid content. Also to remove the indigested toxins, to give antidotes such as activated charcoal, and to give an oral radioplaque contrast agent. Also to provide feeding of nutrients into the stomach, or feeding directly into small intestine with a long, thin, flexible enteral feeding tube. The equipment for nasogastric tube insertion. So we will be needing a protective gloves and a face shield. So we will be needing a protective gloves and a face shield. So in our case, we will be wearing face mask. Also, we will need this. This is a nasogastric tube for decompressing, such as a Levine tube or a Salim-Sam tube. A tropical anesthetic spray, such as benzocaine or lidocaine. Next, cup of water. Next, a lubricant, a Emerson basin, tape, the suction wall. Next. So for positioning for the nasogastric tube insertion. So patient should sit upright in the sniffing position with the neck slightly flexed. So you will be moving the patient upright. So if unavailable to sit upright, patient should lie in the left lateral decubitus position. If the patient is ventilated through an endotracheal tube that protects, if the patient is ventilated through an intratracheal tube that protects the airways, the nasogastric tube can be placed with the patient upright, or if needed, supine. Nasal turbinates can block the nasal passage. There is usually adequate space below the inferior turbinate to the passage to pass the nasogastric tube. So we already put our face mask. We will be putting our surgical gloves. We will check for each nostril by holding one close and asking the patient to breathe through other nose. over the inside nose for any obvious obstruction. Place the towel pad over the patient's chest to keep it clean. Choose the side for the tube insertion and spray topical anesthetic in this nostril and the pharynx at least 5 minutes before the tube insertion. If time permits, give Florimel of 10% lidocaine via nebulizer or insert a 5 ml of 2% lidocaine gel into the nerves. So right now, we will estimate the proper depth of insertion, about the distance from the earlobe. So this is from the earlobe angle. And then to the sigmoid plus 6 inches down to the stomach. And then we will mark it. So we will lubricate the end of the nasogastric tube. And then we will gently insert the tip of the tube into the nose and slide along the floor of the nasal cavity. Aim back down to stay below the nasal turbinate. Expect to feel mild resistance as the tube passes through the posterior nasopharynx. Ask the patient to take a sip of water through the straw and advance the tube during swallowing. The patient will swallow the tube, facilitating the passage into the esophagus. Continue to advance the tube during swallowing to the predetermined depth using the black marks of the tube as the guidance. Assess the proper placement by asking the patient to speak. If patient is unable to speak, has a hoarse voice, in violently gargling, or is in respiratory distress, the tube is properly in the trachea and should be removed immediately. Inject 20 to 30 ml of air and listen to the stethoscope. Inject 20 to 30 ml of air and listen with the stethoscope under the left subcostal region. The sound of rush of air helps confirm that the tube's location in the stomach. Direct gastric contents to further placement in the stomach. Sometimes the gastric content can be aspirate even when the tube is properly positioned in the stomach. Sometimes chest x-ray is needed to defectively confirm the location of the tube in the stomach. If the tube will be used for infusing any substances such as radiopaque, contrast agent, or liquid feedings, an x-ray is highly recommended. We will secure the tube on the patient nose. We will apply benzoin to the skin if available. Use 3 to 4 inches adhesive tape. Glue the rib vertically for the half length attached to the wide half of the patient nose. Then wrap the tail of the tape in that position. Attach the nasogastric tube to the suction and set the low suction. This is for the intermittent suction if possible. So right now, I will be demonstrating to you the process and procedure on how we are feeding our patient using the NGT. First, we need to explain the procedure to the patient that the feeding will take about 10 to 20 minutes to complete, and also explain to the patient that will experience a feeling of fullness after feeding. And then we will assess the food allergies, time of feeding, bowel sound, and laboratory values. Next. We need to place the container with feed in warm water. This is to warm the fluid to be fed. Assist the patient to fuller position. This is to enhance the gravitational flow of wrist through the tube and prevents the risk of aspiration. We don't need to we need to remember to always wash our hands to reduce the transmission of microorganisms. Spread towel and Macintosh over the patient's chest. Once done, glove attached to the syringe Once done, gloves attach syringe to the nasogastric tube. We need to aspirate stomach content if there is a doubt about the tube placement and obtain an order for x-ray. So we can use our stethoscope to check for it. So this is if residual gastric content exceed 100 ml for intermittent tube feeding or greater than 1/5 times the hour rate for continuous feeding, and notify the physician. If the tube placement is confirmed on the stomach, we need to pinch the tube and attach the barrel to the feeding syringe to the tube next. We need to fill the syringe with water and add fluid to flow the gravity by raising the barrel above the level of the patient's head. Pour the feed into the syringe barrel and allow it to flow by gravity. Keep on pouring feed or formula to the barrel when it is 3/4 empty. Pinch the tube whenever necessary to stop when pouring. This is to prevent air from entering the tube. Next. After the feeding is complete, flush the tube at least 30 cc of plain water. After the tube is clear, close the end of the feeding tube. Rinse the equipment with warm water and dry. Keep the head of the bed elevated for 30 to 60 minutes after feeding. This is to prevent aspiration. We need to wash our hands, document the amount of feeding, amount of water given, and tolerance of feeding. We need also to monitor the breath sounds, bowel movement, gastric distension, diarrhea, constipation, and intake output. This is for us to evaluate aspiration effect in the GI system and therapeutic effect of feeding. Instruct patient to notify the nurse if they experience any sensation of fullness, nausea, or vomiting, because this may indicate intolerance of feeding. So once we're done with our feeding, we will be removing the tube from our patient's mouth. So once we're done feeding our patient, so now it's time for us to remove the NGT. So first, we need to check for physician's order for the removal of the tube. Explain the procedure to the patient and assess to the semi-Fowler's position. We need to gather all the equipment needed and then place the hand in hygiene and use gloves and face mask. We will place towel and dispose pad across patient's chest. Give the patient tissue just in case he will need it. Discontinue the suction. So discontinue the suction. And then separate the tube from the suction and pin the tube to the patient's gown and carefully remove the adhesive tape from the patient's nose. Attach a syringe. Attach a syringe and flush with 10 ml normal saline solution to clean with 10 to 50 cc of air. Instruct the patient to take a deep breath and hold it. Dump the tube with fingers by doubling tube it on itself. Quickly and carefully remove the tube while the patient is holding its breath. Place a tube in the plastic bag and remove the gloves together with the tube. Offer a mouth care to the patient with facial tissue to blow loose. Always record the removal of the tube, patient's response, and measure of drainage. Continue to monitor the patient for 2 to 4 hours after the tube removal for gastric distension, nausea, and vomiting.